Well, welcome everybody to this session on Doctors with Heart. My name is Anne-Marie Navarre. I'm an associate professor of cardiology at UT Southwestern Medical Center and part of the American Heart Association's Center for Health Technology and Innovation Advisory Group. I've been excited to be part of the Doctors with Heart development team for the last couple of years, and am thrilled that you're here to learn a little bit about the program that we've started and what our vision is moving forward. I'll tell you more about Doctors with Heart, but before we do, I want to have a chance to introduce all of our panel. I also want to point out that we are paying attention to the chat, and so if you have questions for us, please feel free to put them in the chat. I'll be paying attention and directing questions appropriately. We also already have some important information from Laura in the chat box about two important funding opportunities related to disparities and equity. That information about that is already in the chat box. So with that, welcome to the program. I will kick off the introductions with Cassie Walker from CHTI. Cassie, tell us a little bit about who you are and what your role has been with Doctors with Heart.
Thanks, Dr. Navarre. Yes, I'm the program director for Doctors with Heart, and I work within the Center for Health Technology and Innovation here at the American Heart Association. And I led the initial pilot phase of Doctors with Heart, and that included overall program management, communications, working with the health centers, the volunteers, the funders, and of course the technology platforms, including the telemedicine platform. And I really feel fortunate to have come on board with this program at its beginning, at least operationally, as I've been able to take the vision, this amazing vision that was established by Dr. Navarre, by Lynette and Patrick Waite here at the Center for Health Tech, and to nurture that vision and try to bring it to life in a way that meets the goals it's meant to meet, which is primarily improving access to healthcare. So we learned a lot during the first pilot this past year, and now we're working on scaling up and expanding that vision to better serve all the people and organizations that are involved in working towards the AHA's mission of helping people live longer, healthier lives. And Doctors with Heart is just such a great piece of that.
Well, now let's go to Dr. John Osborne, who's actually one of the very first AHA volunteers to provide consultations with Doctors with Heart. Dr. Osborne, tell us who you are.
Well, good morning. I'm John Osborne. Actually, it's funny, I met one of your colleagues, Anne-Marie Navarre, and was a fellow with him at the Brigham many years ago, Eric Peterson, and moved to Texas after I finished my fellowship. I got called back to the farm back then and have been in North Texas ever since. I'm in private practice, but have always been very involved with the community and always very much interested in helping spread information and education and medical education, and trying to serve as mentors to people in the medical community. I've done a lot of, I've evolved into a preventative cardiologist. I haven't been in the cath lab since 2006, cardiac CT, cardiac imaging, and preventative cardiology and lipidology are really my main passions and interests on the clinical side. About a year ago, Cassie, I'd been working with the AHA as working with media as a volunteer for them for media opportunities and for the AHA to spread the message about cardiovascular disease and prevention. And about a year ago, Cassie gave me a call and told me about this program, and I immediately said, yes, sign me up. And it's been a great thing since.
And it is my absolute delight to get to introduce our final panelist, who happens to be my mom, Lynette Navarre.
I'm Lynette Navarre. I am a nurse. I've actually retired, but I worked for Mission of Mercy for the last decade or so. And Mission of Mercy is a free nonprofit clinic that takes care of the un- and underinsured. And we often ran into, as you can imagine, patients that were very ill with just incredible heart disease. And our medical director, who's internal medicine, would reach out to me and ask me to call Anne-Marie, Dr. Navarre, for information, for help with managing these patients. So this went on for quite some time. And through all of these visits, Anne-Marie came up with this wonderful idea of Doctors with Heart. And so anyway, we were also the first clinic, and I believe with Dr. Osborne, to actually launch the program. And it was delightful, and it's just an amazing next step to actually prolong these patients to a healthier, longer life.
So maybe I'll just give a little bit of context about what Doctors with Heart is before we launch into specific questions. So first, I want to thank everybody on the panel, with a special thanks to Cassie Walker, who has really been, when she says program manager, she's the reason that this program exists and is the catalyst for getting everything off the ground. Us crazy volunteers with a vision, she actually turned it into a reality along with the support of the Aetna Foundation. So thanks also to the Aetna Foundation. So as my mom mentioned, she was the nursing director at Mission of Mercy and was responsible for basically plugging any holes in the clinic that needed plugged. And oftentimes there were patients who needed cardiology consultations. And while there's a number of really generous other medical professionals in Corpus Christi, Texas that are available to support, there often was a challenge in getting patients sort of referred to the clinics in a prompt manner. So I had become sort of an informal consultant available via telephone or email for any patient that was seen by Mission of Mercy in Corpus Christi who needed a cardiology consult. But what I realized is like not everybody's clinic has a daughter that's a cardiologist that can provide support. So what if we could figure out a way using telemedicine to democratize this process, realizing that there's just a ton of people, a part of the Heart Association, physicians who would be willing to provide their time and energy and support for these types of consults. And there's probably a lot of clinics out there that need support as well. So we dreamt up Doctors with Heart, which is essentially kind of a matchmaking program between cardiologists who are interested in volunteering their time and free or low-income healthcare clinics that needed access to specialists. We developed a telemedicine-based platform that allows doctor-to-doctor video visits that also has a HIPAA-compliant area where we can write notes and share clinical information back and forth. And then centrally, there's a scheduling hub that Cassie ran that allowed cardiologist volunteers who had time to match up with clinics who needed consultations in order to facilitate these conversations. And we piloted it last year. As I mentioned, we had the support of the Aetna Foundation to get this off the ground. And we built a telemedicine-based platform on one of the commercial telemedicine company infrastructures that then supported the actual operations of Doctors with Heart. Cassie, tell us a little bit about the details, since I'm a little bit fuzzier here. You know, how many different places were we able to pilot in last year, and when was our very first consultation?
Yeah, so I feel like we can't have this conversation without mentioning the pandemic. If you recall, we started working on this operationally in March of 2020. And fortunately, we had great interest from the health centers and fabulous interest from the volunteers. We had no shortage of either side of that supply and demand equation. But it was challenging for all the reasons you can imagine. Because of the pandemic, we decided to expand the initial scope of the pilot and try to include a few extra clinics because we didn't know what the impact would be. And we also just saw so much need and interest, we wanted to pull in more folks. So we started with 6 who were really interested. We lost 1 or 2 along the way just because of the capabilities or capacity that they had there at the health center during the pandemic. And we were able to launch with 3. And the first one was, of course, Lynette's Health Center there in Corpus Christi, Texas, Mission of Mercy, which we started in September of 2020. So we were able to accelerate some timelines and, despite tons of interest in telemedicine platforms at that time, we were able to get our instance up and running and bring Mission of Mercy online followed by another health center in Northern California and one in West Virginia. So we had a nice mix, a couple of really truly rural health centers, as well as the one in Corpus Christi, which serves a rural population. So, that was one of the key things for us, is we wanted to have different geographies and different populations that we were helping and people that we were helping, so that we could learn as much as we could about what was similar and what might be different.
So, Dr. Osborne, you were one of our vanguard volunteers providing these types of consults. Tell us a little bit about what a consult was like. What are the types of topics you covered, and how did it work from your end as a provider?
Yeah, so I have to tell you, the programs for me has been extremely rewarding. I love talking medicine. I love reaching out, and it's really been fantastic to be able to be hooked up with the system that you guys put together, and Cassie, to be able to, when there are cardiology questions, that I can help and assist and guide them. And it's amazing too, if you look at, meetings like the HA, and this meeting, of course, not unique, is just this incredible amount of information. And, keeping up with your information cardiology is always like drinking from a fire hose. So it's very humbling for me when I talk to some of the providers in the system, where there really are highly resource constrained. And it's been great to be able to help and assist them with this program. And I think it's been great for me. We get so used to having tremendous resources and in places like North Texas, and then when you go to places like that are financially constrained, and for instance, like in rural North California, it's just great to be able to help them walk through clinical scenarios. Most of the stuff that we've talked about really is kind of bread and butter cardiology, but mixing in complicated patients, as is always the case in medicine. And hypertension, heart failure, a lot of heart failure, as you can imagine, and then just management of chronic coronary syndrome, and then lipids. So, pretty much bread and butter cardiology, but the challenge has been how to make things happen and figure out how to answer questions where resources are limited. That includes not just community resources as far as cardiologists go, but also even just access to imaging, which obviously is pretty critical in cardiology. But that's kind of made it more fun and exciting, trying to figure out these dilemmas and how to provide, really excellent cardiology care and via the providers in these different systems, but work through the constraints and the lack of resources that they have. But I think it's been great because I've really focused on guideline-directed therapies, trying to translate all of the data and science and literature and of course guidelines in cardiology, and rapidly get them up to speed as well. Because I have the luxury of being a mile deep in cardiology and an inch wide, whereas they have to be a mile wide. And again, it's very humbling. I think I'd panic every day when I walked into the office if I had to manage all the things that they have to manage. And it's wonderful to be able to just do my little cardiology bit and then be able to help and assist patients and their providers in places where otherwise we'd never have the ability to interact.
Yeah, thanks, Dr. Osborne. That's a great summary and sort of a reminder of kind of why we do medicine in the first place. It's fun. It's also a nice reminder of why we actually did this as a doctor-to-doctor consultation program. As part of our early feasibility discussions, we actually considered, should we do a doctor-patient virtual visit? Could we set up a kiosk in free clinics, or some way that we could do direct-to-patient consultations? And while a lot of the technology is there to do that, you can even get a kiosk that has a stethoscope and listen to somebody's heart sounds from anywhere in the world. The resource issue was really a problem. We weren't able to know what's on different people's formularies, what labs people could get. Could you get access to an echo or a stress test or a heart cath? And so we really felt it was important that we provide recommendations to the patients that they would be able to actually implement. And really the only people who know that are going to be the people at the individual clinics, the providers at the individual clinics. So we set it up as a doctor-to-doctor consultation, largely because of that resource constraint. But I found in some of the consultations that I've done that one of the best, I guess, secondary effects beyond that individual patient consult is there's an educational component, and there's a really nice back and forth. What do you do when this drug isn't working, or how do you choose between A versus B? Tell me a little bit about your management approach to XYZ. And so I think it's a nice way to have kind of informal collaboration and education that can then affect care for not just the one patient we're consulting on, but actually all the patients at the clinic. So, Mom, I can't call you Lynette. It's weird. Tell us about the experience from your end. You were part of Mission of Mercy for over a decade, taking care of patients. Tell us about the challenges that you faced in specialist care, and what it was like to have the Doctors with Heart program available.
Well, we'd have the sickest of the sick, because they obviously, with no insurance, had not received care in many, many years. So many diabetics. And so along the way, untreated hypertension, they developed a fair amount of heart disease, which our physicians were fairly good at controlling many of the general symptoms. But then the patient eventually would go to the hospital in congestive heart failure or have an MI, and then things turned topsy-turvy, and they showed back up at our clinic with a multitude of instructions and new meds and tests that they needed to get. If we were fortunate enough, they would have been worked up in the hospital, and we could pull echoes and stress tests and many, maybe even heart cath results. If we were unlucky, they showed up with a note that said, "See your cardiologist." So from there, then we had to look into, could we get an echo? Well, yes, for $75. Okay, can the patient afford it? Well, no, but I can pay it off. Can we get a stress test? Well, that would be $210. So there were just really a lot of items that held back that care on the patient. Of course, they would be discharged on some of the newest, best medications, which were not possible to pay for. So luckily, we ran a prescription assistance program, which did help. So anyway, the problems were just immense, and on and on. We had one patient show up after being told from a hospital visit that she was in congestive heart failure, and she had 5 years to live, and which was just devastating. And it was really wonderful to say, hey, let's not give up. We're in this program now called Doctors with Heart. We have access to excellent cardiologists. We'll get you going there. So anyway, that's where Doctors with Heart came in. And it was for Dr. Porter. He dealt with Dr. Osborne several times and absolutely loved learning from Dr. Osborne. Just a wealth of information. So anyway, that's sort of where we were with the problems.
So I think it's a great reminder that often the things that we recommend to patients when they're in the hospital, or to say, go follow up with your outpatient doctor about XYZ, make sure to get even something as simple as a follow-up BMP, check potassium, isn't always so straightforward for a lot of our patients. And so one of the things that we found that was really nice as Doctors with Heart is being able to kind of troubleshoot, okay, well, maybe the person was discharged on, 5 different medications. let's talk to the clinic, figure out what you can get a patient assistance program for. So maybe we can't get an SGLT2 inhibitor, but actually patient assistance is pretty good or easy to get for an ARNI or Entresto. So, making changes where we can to make the medications affordable, getting on the right doses, figuring out what's the, minimum number of tests that you need, what's sort of in the nice to have versus no, you really do need an echo versus actually, no, they had an echo in the hospital. They're okay. You don't need it. Get another one 6 weeks from now. It's fine. So I think there was a lot of troubleshooting to figure out how do we get the best therapies on board in a way that the patient can afford and they can continue to take over time. Cassie, you talked a little bit about the challenges of the pandemic and just getting it off the ground. We had clinics shut down entirely, staffing shortages. Everybody was sort of distracted by COVID for a while. But there were other kind of challenges or lessons learned that were kind of independent of the pandemic as we think about, where we go in the future and how this scales. Tell us a little bit about, from a program side, what surprised you? What did you learn about, this type of approach?
Right. So first, I do want to circle back a little bit to what Dr. Osborne and Lynette were talking about, that degree of knowledge transfer and Dr. Osborne being able to talk about things broader even than just that particular patient case. And that was such it wasn't that it wasn't foreseeable, but I think the level to which that occurred was at least a little bit surprising to me, and something, that we definitely want to capture and bring forward and expand upon as we move forward with the program. But as far as the challenges with getting started, it kind of fell primarily into two categories. One was really working within the workflows of the health centers. So, as we've talked about, that they were up to their eyeballs in COVID and other things, and as they normally are, everyone there is just really maxed out when it came to time. And so we were able to have a very robust telemedicine platform that had all the bells and whistles and could do everything we needed. But in the pilot, it turns out we didn't need that much. And one of the key learnings was that we needed to make sure whatever we instituted in the health center fit with their technical capabilities, their capacities, and even just where they would feel comfortable with scheduling patients and uploading records and doing, connecting with the cardiologist. It all needed to flow seamlessly. And it was a challenge. It was definitely a challenge. So going forward, that's something we'll definitely be working on. Another thing, I think, kind of in that workflow area was the difficulty that they had even just making time to do the consultations themselves. That presented a huge barrier. Because the scale of the pilot was so small, we began with scheduled consultations. And I considered it kind of a matchmaking process. So I would find out when the availability was at the clinic, when the physician at the clinic had time to conduct a consultation. And then I had to find a cardiologist who also had availability during that time. And so two very busy groups of people, we had to really kind of matchmake. It's like match.com for telemedicine to make that work. And if somebody had something come up, which happens so frequently in all of our lives, the consultation might be delayed. And so as we move forward, we're looking for ways, we're going to be testing some ways to make that easier, perhaps with ad hoc consultations, kind of, it's been dubbed phone a friend. So phone your cardiologist friend and get some information, as well as maybe some more informal communications channels. So I think those were two of the biggest learnings we had from the pilot.
Yeah, I think it's a great point. I remember in the early design phases, we were looking at all of these fancy, video and this and the record sharing, and you can have 17 different notes with templates and yada, yada, yada. But really all you need is a way to have two people connect. We kind of all know how to Zoom video now at this point. We need to be able to share records in a HIPAA compliant way. It's nice to be able to see the EKG, see the echo reports, see the labs. And then it's the scheduling. I'm not sure that, a lot of the other tech was all that needed. I don't know. What are your thoughts, Dr. Osborne?
Yeah, I agree. I think probably Cassie and I spent as much time just on the scheduling part, and that was my fault, not hers, obviously. But oh, can you do this? Oh, I can't do that, and and that really was at least I can imagine on her end was a lot of the workload, just that aspect alone. But of course, she was incredible at doing all of that, and has been incredible at doing all that. But yeah, I think the scheduling is really the one of the most important aspects of that is just connecting two people. The rest of it really kind of occurs organically, and of course, having the ability to pull up labs, echo reports, things like that, be able to discuss those that bit of data with the provider is really fantastic as well. But I think that's sort of almost the gravy to this issue. It really is just that. Putting a person next to another person and, provider next to another provider, and then just saying, here's the scenario, here's what's going on, here's the problem, and again, it gets back to foundational issues of medicine. Medicine is fantastic. It's fun. It's exciting. And only the tools and only get better and better, and the science gets better. And of course, that's why I get drawn to this program, to be able to share that. And that really has been just incredible for me. But the process that you guys have put together, the system that you put together really is phenomenal for us to be able to reach out. And to some degree, thanks to COVID, frankly, for really kind of pushing this whole technology into the forefront. So, but yeah, Cassie's been fantastic, and a lot of it is just it's it's scheduling. The rest of it sort of occurs naturally.
Well, and after that, I have to say, Dr. Osborne is just a natural fit for this program. You could just see his love of not just cardiology and medicine, but people, and passing his knowledge on to others and being helpful in that way. So, I can't take a compliment without giving a compliment, because it's definitely well-deserved.
And I think part of this issue is really that fish and fish hook issue, right? I think if you deal with a patient, you can kind of solve perhaps an issue of many complicated issues at that moment. But again, you can't connect what testing needs to be done, or imaging, or drugs they need, and all that stuff. Whereas when I talk to a provider, I can give them the concepts, the foundational issues that not only are going to be useful for that patient, but then for the next 20, 50,000 patients that provider sees that are dealing with the same issues. And so that's really what makes it a lot of fun, is knowing, we're talking about a patient, but really we're going to be helping just a number of other patients that have similar issues. And again, makes it extremely rewarding. I think certainly for me, and I think helpful for the provider, and ultimately, it's how do we amplify ourselves and use force multiplication. This is really force multiplication at a dramatic level, where we talk about a patient, which then leads to a concept, which is then going to be implemented in scores of patients, hundreds of patients.
Now, Mom, tell us about the scheduling on your end. We talked about our side, but how do you fit in doing this with all the other stuff that's going on in a clinic on a day-to-day basis?
Well, it was difficult, and the pandemic really put a crimp in it, because we usually worked with a large volume of volunteer nurses and such. And without those volunteers, then our tiny little staff, it was me, one RN, an LVN, and she worked with the computer part of Doctors with Heart. it limited what we could do. It was just the two of us for almost a year in that clinic helping. And we brought in minimal patients, but we did a lot of video conferencing, the physician did. So finding the time was difficult. And part of that reason was because we are an old-fashioned chart, paper chart. And so I would want to get a hold of all the information and organize it before it was uploaded to the outreach physician. And so there would be something that made sense to the physician to look at other than digging through pages of notes. So it was fairly time consuming to get it organized in such a way that once the two physicians actually were talking to each other, they could go through it and make sense out of it. So anyway, that's our biggest challenge. So the pandemic was a problem. I suspect it would not be so much had we not been so limited on our actual staff.
I think on the flip side, though, what the pandemic has done is created basically an entire nation of people comfortable with a telemedicine-based interface. So everybody now knows how to talk on the computer, talk via video. And in fact, we learned that even in some of our more rural locations, basic Wi-Fi was sufficient for us to have a video dialogue back and forth, to be able to share images like EKGs and echo reports. So although there were challenges in terms of availability of patients and staff in our first pilot year, I think that the lessons from COVID and the realization of how easy it is to connect virtually will serve us well as we think about expansion. So on that note, I'm excited to have Cassie tell us a little bit about maybe where we're going next year. And I'm thrilled that we've been able to continue to receive the support of the Aetna Foundation in these efforts as we grow into our next phase.
Yeah, thanks, Dr. Navarre. It's all a labor of love, I feel like, for all of us. And one of the challenges has been, post-pilot, where do we go from here? How do we take what we've learned and build on the things that worked and make adjustments for the things that didn't? And so, I think what's key for us here at the American Heart Association is that this program fits so neatly within our mission and our impact goals of improving access and quality of healthcare to everyone. And so because of that, we're getting a lot of internal interest and internal support in finding ways to help the program grow. So as Dr. Navarre mentioned, it's now the Aetna Foundation, we just found this out this week, that they are continuing their support of the program for this next phase, scaling up. Huge news, exciting news for us. So one of the things that we really want to make sure we build upon is that element of knowledge transfer. And to do that, we're looking at tackling it a couple of different ways. One way is by providing additional cardiovascular cardiology education to physicians and other clinicians in the health centers. But we'd also like to further connect the health center staff with each other. One of the things we found out in the pilot was that, particularly in the rural areas, some of the health center providers were pretty isolated. One of the health centers, it was a nurse practitioner who did the actual consultations with the cardiologists, and it felt like sometimes it was just nice for her to talk through things with another clinician. And we want to enable that in a natural way, providing some sort of, we're still working out all the details on this as to how it'll work, but like a virtual community of practice to share lessons, to connect, to ask each other questions and that kind of thing. So that is one piece that we are really focused on building, in addition to kind of making all of the technical issues and challenges easier, improving the ability to connect kind of more ad hoc. And then really it's a matter of taking a look at the individual communities and the populations that we're serving there and seeing where else can we have an impact? Where can we tie into other AHA programs, for example, or other efforts that are being done within the community? Because, you know, the people that are coming to the health centers, their lives aren't in a vacuum, right? There's a lot of social determinants of health and other factors that that need addressing. So that's something we're beginning to look at as well.
I'm really excited about growing. The first 3 clinics we had, Mission of Mercy, Corpus Christi is a town of about 400, or city of about 400,000 people. So not the same as a city like Los Angeles, but, you know, more of a, you know, not rural, kind of urban population. It actually got a bus line put in right on the clinic that they built to get people into the clinic. We had a Mission of Mercy, an Indian Health Service clinic, which was sort of part of a different network altogether, but also had challenges in terms of access to specialist care, and then a clinic in West Virginia that was more rural. And I think it's been nice to be able to see the program work in different types of clinics. That was one of the goals for the pilot. So as we seek to expand, I see Dr. Galati asked a question about expansion beyond Texas. We are, now that we have finished the pilot program and are moving to expand, we're actively looking for more health centers that we can partner with. We're working on refining our platform so that we can have a little bit easier scheduling, and then we'll be expanding our numbers of volunteers that we'll be working with to have access to specialists. A couple of things I'd like to see done in the future, probably not next year, but you know, once we've continued to grow. We know the Heart Association is more than just cardiologists. There's some incredible nutritionists, endocrinologists, neurologists, you know, lots of different both physician and non-physician specialties that I think we would have a really wealth of talent that we could bring and volunteer with these health centers. I'm also excited about the idea of better education. I think the AHA's quality group that Get With the Guidelines program has a great model of big seminars that kind of disseminate information about guidelines, about best practices to all those participating. I'd love to see a similar education network with Doctors with Heart participating clinics, where we could have volunteers not just give consultations one-on-one, but perhaps lectures like, what do you need to know about hypertension guidelines, or how do we talk to patients about statins and things like that. So there's a lot of room for both educational expansion, but also just expansion on the clinical side. And we'll be looking to do both in the next year. Let me ask maybe Lynette, what would you like to see if you could, tell us, from a Doctors with Heart standpoint, what do you think we should do? How could we best benefit the patients that you take care of?
I love the education, and I would like education that was actually, sort of an 8th grade level education that we could actually print off and give to the patient. Education was a huge part of our clinic with diabetes, various aspects. And so that's what I would really like to see. Perhaps there could be a simple program that you could put up for the patient to look at while they're sitting in the clinic that talks to them about various things. So just bring it down where it's very non-intimidating to the patient, and anyway, go from there. I would really like to see more education.
It's a great point. A reminder that it's not just the doctors we're working with that need to learn things, but our patients as well. I think AHA's done a good job in the last few years of revamping a number of their patient-facing websites with various educational materials. But I think a lot of places still really depend on that sort of, wall of brochures in the waiting room that people can peruse. And I like the idea of leveraging some of that downtime in the waiting room to, instead of having people, play games on their phones, maybe we could be showing people videos about blood pressure or, healthy eating. Dr. Osborne, oh, go ahead, Cassie.
I was just going to say, one of the other things in addition to Doctors with Heart that we do at the Center for Health Tech is work with generally younger, though many also established, innovative health tech companies to figure out ways to use their platforms to disseminate the AHA, what the AHA does best, which is research and providing science. And so that's an ongoing effort for our group, the Center for Health Tech. And then, of course, hearing Lynette talk about ways to get education in the hands of patients, that's where my mind goes immediately. So I think there's a follow-up conversation to happen there about how can we engage patients directly, because we have the means and we have the ways to do it, while they're just hanging out there in the waiting room, for example. So thanks for that idea.
Let me just ping that real quick back to Mom. We often talk about, one of the things we worry a lot about at the Center for Health Technology and Innovation at AHA is how do we make sure that these advancements in health technology don't widen gap in health disparities, making technology that works for the rich and well-connected, but that we can't get to our perhaps neediest patients. What % of the patients that you have, that you see at Mission of Mercy have a smartphone, have access to either a cellular connection or Wi-Fi? Do you think that gap is closing, or would we be missing a lot of people if we were focused mostly on sort of a smartphone-based, educational platform?
Well, I think a lot of people are getting them. The gap here is knowing how to use them. That's a huge gap. And unless they have a grandchild or a child that can show them through it. And we saw a lot of this trying to do video conferences with them. And of course, outlying areas that we took care of, reception was poor. I mean, there still are a lot of problems with the type of patients that we are, actually that gap of patients that we have. So, the simpler, the better. I know big platforms are wonderful, but we've got to be able to not intimidate these people so that they will get on and look at it. If they feel intimidated, they're not even going to try. So anyway, I don't know if that answers your question or.
No, I think it's great. And it sort of takes me back to, the initial launch of the program early on, and thinking about putting together our advisory board. And it was really important for us to have representation from the clinics who are going to be using the platform. We often think we know what clinics need or what might work, but we really have no idea unless we talk to the folks who are actually on the ground. And we say, oh yeah, everybody has access to, everybody can get access to Wi-Fi or video. But maybe they have it at the clinic, but if the doctors are doing the consults back at home, maybe their internet connection isn't as good. Or if it's asynchronous with an actual patient visit, then the provider has to go back to the patient afterwards and connect with them. And, there's challenges with follow-up. So we learned all these lessons along the way, but it was really important for us to try to pre-learn as many of them as we can by having people like you, Mom, and others guide us as we develop the program in the first place.
Well, can I make one other little point? We have a lot of retired physicians that go out and volunteer at these clinics, and they too are very intimidated with a lot of the computers now. So again, simplicity for that group also would really help. I speak from experience. So anyway, just a heads up.
I think it's important. I think we still have a lot of knowledge gaps about how to use some of these interfaces. So, Dr. Osborne, what do you tell us? What you think the future of this type of platform is going or should go? What are your thoughts for us as we think about expansion?
Yeah, so I first of all have to address Lynette, and once she said this, I felt much more calm and relaxed. And, most of my vocabulary and concepts really don't ever go beyond 8th grade. So this is really, I am perfect. I'm a perfect match for this program. I think it's great to have the technology. I think we need to, obviously there's issues of expanding that. Many people have Wi-Fi access into our smartphones, so that's certainly helpful. I think one of the biggest challenges though, and this has been a forever challenge, and this is for everybody, is engagement, motivation, particularly for an asymptomatic at-risk patient, whether it's heart failure, coronary artery disease, diabetes, hypertension. Early on, these long-term progressive and ultimately fatal diseases have no symptoms. And so the challenge at the patient level is really getting patients to say, hey, wait a minute, I need to do stuff now and make an investment now in my health, in diet, exercise, lifestyle, smoking, et cetera, so that I avoid lots of really, terrible morbidity and ultimately mortality. So I think that's always a massive challenge. Hopefully technology will help us to educate patients better, and then that will ultimately change outcomes. And then patients that are sort of in the system, I think the flip side of that issue of engagement and motivation, if you have heart failure, you feel bad, you're going to seek help, you want to feel better, as an example, or angina. And that flip side in patients already in the system is really adherence and compliance. But it's exciting to hear from Cassie as far as, we're having tech reach out to her, and then the system can really be an alpha or a beta system to be able to test these ideas rapidly and quickly, to be able to see how well they work and achieve these goals. I think the other exciting thing, and this is the long term, although I think we're already in it already, is really revolutions in imaging. And new sorts of imaging. I'm a huge fan of cardiac CT, calcium scoring as in the primary prevention space, which is ubiquitous, relatively inexpensive, and very exciting as a tool to provide diagnostic to diagnose a variety of cardiovascular issues, and of course then non-invasive echo. And then the other major issue going forward is that I think cardiology, as much as I think we tend to be very, very high tech and we like all the fancy, we like all the fancy tools and all of that, I think cardiology is certainly very much evolving back to its roots, which is really a medical profession. We were largely surgical for a long time, and there are people that basically practice in cardiology in a surgical sense. But being a preventative guy, it's about TLC, diet, exercise, lifestyle, and then making the right diagnosis, and then the appropriate medications. And I think we're really getting back to that cardiology as a medical specialty, focusing on the foundational issues of correct diagnosis, and then using evidence-based approaches and medications. Of course, that becomes a whole other issue of who pays the bills and all of that. But we'll bite off a little bit at a time here with this program.
I think you make a great point, John. There's a lot more to do, and there's a lot of exciting advances in cardiology. I hope that this type of program can help get those advances to communities that need it most. Though it's a challenge, a coronary calcium scan, I think the cheapest I can find it in Dallas is $75. That's too much for patients who have no insurance and are having to pay out of pocket for all of their medications. Mm-hmm. On the other hand, there are ways that we can, get, other either philanthropic or volunteer programs, connect them to these types of clinics with Doctors with Heart. Even things like home blood pressure cuffs. There are programs to support access to them, but we need to help clinics figure out systems to, manage them and respond, et cetera. So we are not, I don't think we're kidding ourselves that just a consultation with a cardiologist is going to solve all the problems. We think it helps. But my hope is that as we get more and more clinics connected, and, as Cassie talks about, sort of a system of practice, we can then start figuring out, hey, how did Mission of Mercy get 50 blood pressure cuffs that they're doing home blood pressure programs for their patients? And how does that clinic in, Kentucky get free coronary calcium scans from this radiologist group on Saturday or whatever. I think that we can start figuring out ways to disseminate learnings and also figure out how to incorporate some of the newer developments in technology and imaging in ways that actually make sense for the clinics that are taking care of these patients. May not work for everybody, but can start to share some of those learnings. And I guess since we have about 10 minutes left, we'll start to wrap up with some closing thoughts. I'll start here with Cassie, and maybe just sort of let us know, what's been the most exciting part of the program to you, and what are you looking forward to in the next year?
That's a good question. Good way to wrap up. I think it was a fun challenge to operationally get things up and running. But the most exciting part to me is when the consultations actually occur. And Dr. Osborne one time made a comment about a specific patient and saying, we're going to add years to his life and he's going to feel so much better. And that, I think I told everybody I saw that for about a week, because that's what it's all about, is having that impact on individual people. And so to be able to scale that up to reach more people, that is definitely what I'm most excited about. And the rest of it is how do we get there? How do we best get there? How do we learn, make mistakes, learn from those? How do we learn quickly, change direction, implement, and impact more people? So that to me is what I'm looking forward to the most, is being able to scale this up.
Dr. Osborne, do you remember that patient?
Yeah, I do. I think it was a patient with heart failure, which again is the classic scenario. You feel horrible, you can't breathe, you're drowning, right? And you can, with the right tools and approaches and medications, and some of these medications are fortunately incredibly cheap. The standard bearer of heart failure is $12 a year for your beta blocker, your ARB, ACE inhibitor, and MRA. And then we get into the more expensive drugs. But just doing that on a very reliable, regular, organized basis can help tremendous numbers of people with a very, very low price tag. And I think it's been really an honor for me. And this year has gone by incredibly fast. It's been an honor working with you and working with Cassie on this program. And I really am excited about it. I hope it continues to grow, and I hope that I continue to be invited back to participate. It's been incredibly fulfilling for me. And I think at the end of the day, it really is about that one-on-one connection that I think that's how we learn medicine. That's how we practice medicine. That's how we teach medicine too. And it's all case-based. And you'll never learn better than that patient that you remember, Mrs. Jones, who had this problem and you treated this way and was successful. That's a never forget educational point. And I'm just excited to be a very small part of that.
But we do have some questions in the chat that we will get to if we have time. But I want to ask one question of my mom before we run out, which is, we've got close to 100 folks here watching and more that'll be watching this recorded program. Many of these folks watching are health, either physicians or other providers that may be thinking about volunteering with us at some point. You left nursing at in the ICU in a big hospital to go work at a free clinic taking care of the underserved. So you probably more than any of us understand the mission and the spirit of this type of work. For people thinking about either volunteering with us or finding other organizations locally that they can do this type of care, tell us why. What's in it for you? What does it feel like to be a provider to these types of patients that we get to take care of?
I think one of the best things that has ever been said to me by a patient is, oh my gosh, I have hope. That was key to everything. Perhaps we can't cure them, but they finally have someone listening to them. And there's a feeling that they are important now, which means they will embrace their own health a little bit more. We had actually a cardiology patient that came, was having chest pain. We sent him to the ER. He came back with a stent. And he said, you know, I'm turning my life around. I never thought I'd live past the age of 40 something. Nobody ever cared. He said, but y'all really do care. And he was our patient. Well, when I left, he was still our patient, but he had started his own housekeeping business. I don't think unless you actually get in there and spend time with these patients that have not had access to care, that have been really kind of minimized, can you really understand what they need and what little it takes to actually make a difference. I really was very humbled by all of these patients I took care of. They taught me more lessons than I'll ever learn from anybody else. So they brought a purpose to my life, a deep soul searching purpose. And anybody that's the least bit interested should really give it a try. It takes little to make a difference in someone's life. So.
Well, that is just a phenomenally inspiring sort of way to wrap us up. I think we'll probably go ahead and close with just a couple of quick responses to the two questions in the chat box. The first I'll send to Cassie, which are, who have we partnered with, community-based or advisory boards, to help overcome needs and ways to overcome barriers to implementation? We've actually done some of this, but tell us a little bit about who our partners have been and who we've gotten input from.
Yeah, so we're lucky to be able to work with our field staff on the ground who have connections into community-based organizations and in health centers themselves, and being able to tap into those networks has been really useful. You know, I'm just blanking on everyone that we work with, because I think it is a challenge to kind of make that a systemic effort. And that's what we're looking to do in this next phase, which is figure out, okay, how do we replicate the partnerships, if you will, the relationships with organizations, kind of, and then scale those up. Dr. Navarre, did you have any additional thoughts you could add to that question?
I think it's great. You know, we've had input from doctors and nurses and staff at the clinics that we've, from launch through implementation. We also have had input from the American Telemedicine Association. We've had, professional assistance from them. Somebody asked about malpractice insurance. That was a whole, that took a lot of input from various people. That short answer is that because we do doctor-to-doctor consultations, we're actually pretty shielded from malpractice issues, because all of the recommendations and things go through the local physician. But if you're interested in joining us and sort of putting your name on the list for future volunteers, I would, is it okay, Cassie, if they email you?
Yes. Cassie.walker@heart.org.
And we will, we can give you information about, any coverage or other concerns that you might have about that. And then as we seek to expand, excited to bring you in. If there's special things that you're interested in too, let us know, because we may be moving into certain subspecialties, say, electrophysiology or prevention. So if you have a particular interest, let us know, because we may be able to start to earmark those in the future as well. Somebody asked an interesting question about increasing access to cardiovascular imaging, and we probably don't have time to get into that, but I would actually push it back to you, Dr. Haller, to to say that if you have ideas, I think if anybody out there has ideas about how we might be able to, start to test out other ways to democratize access to high quality cardiovascular care beyond just connecting doctors to clinics. There's a lot of new advances in technology, handheld ultrasound, machine learning based algorithms to guide people to capture basic images, remote reading, et cetera. I think there's a lot of room for innovation, but we need people and their great ideas as well. So if you have ideas or interest, either through Doctors with Heart or the Center for Health Technology Innovation, CHTI, is always looking for interested partners and great ideas that we can try to expand and start to close the gaps in what we can do for patients and what we do for all of the patients that we could potentially reach. So with that, I just want to thank you all for your participation today. Everybody who joined the panel or who has watched it streaming, I want to thank my mom with Mission of Mercy, who inspired this program to be created to begin with, Cassie Walker, and then the rest of the team at CHTI, including Patrick Waite, the head of CHTI, who really helped move this forward at an organizational level. And then Dr. Osborne for joining us on the ground and being one of our very first consultative cardiologists through Doctors with Heart, leading the way and showing us what we can do.
You survived despite me.
You've been wonderful. Thank you all. Have a great rest of your scientific sessions. And then if you scroll to the very top of the chat, you'll see some great new AHA funding announcements targeting disparities in health equity that if you're listening to this session, you're probably interested in as well. So check out the chat, and there's a hyperlink to that information also. And thank you very much for your participation today.
Thank you.